Hello everybody, we will talk today about an important topic for every physician, not only cardiologist, which is how to read ECG. Starting with this common scenario, 45-year-old male patient presenting to emergency with acute chest pain. To discover the nature of this chest pain, is it ischemic or not, we have different modalities, but among these modalities ECG is the one of choice because it is simple, rapid, cheap and available. So starting with background on our conduction system. As we all know, the electrical activity of the heart starts at the pacemaker of the heart, which is called the SA node in the right atrium. Then the depolarization wave travel among the atrial wall from right side to left side, then along the conduction system, his Purkinje system to both ventricle, causing depolarization of both ventricles. The direction of conduction is from atria to ventricle, so it is downwards, followed by repolarization wave as seen here. So the electrical axis of the current of depolarization is moving from right to downwards and to the left, and this is important for the other slides. So how to record our electrical activity? Here is the ECG machine. We have 4 cables for the 4 limbs and 6 cables for chest. Where to place the ECG leads? We have the red cable for the right arm, the black cable for the right foot, the yellow cable for the left arm, and the green cable for the left foot. So a mnemonic: fire not seen, red and black on the right side; desert become green, yellow and green on the left side. But why the right foot electrode is not seen? Because actually this electrode is not recording electrical activity of the heart. It's just an act to remove the noise recorded with the other electrodes. So the functioning electrodes that record electrical activity are the right arm, the left arm and the left foot electrode. Then we have a chest electrode. Where to place the chest electrode? The first and second one are placed in the fourth intercostal space, one on the right side of the sternum and 2 on the left side of the sternum. Then the fourth electrode placed on the fifth intercostal space at mid-clavicular line just below the nipple. And the fifth and sixth electrode are placed also in the fifth intercostal space, but at the anterior axillary line and at the mid axillary line. The remaining electrode number 3 is placed between lead number 2 and number 4. So the idea of the QRS or the ECG picture from different electrodes are actually the same as capturing the same object like Eiffel Tower from different angle. For example, here we are looking to the electrical activity of the heart from the right side in V1 and V2. We have a different morphology than that recorded on the middle of chest at V3 and V4 and on the lateral wall of the chest at V5 and V6, but all capturing the same electrical activity. So how the recorded QRS complex look at V6? V6, as we just said, lies here in the fifth intercostal space at the mid axillary line. So we are looking to the electrical activity of the heart from this side. The depolarization of ventricle takes 3 phases. The first phase is depolarization of interventricular septum, which takes place from the left side towards the right side. So the depolarization vector of septum depolarization is directed away from V6 electrode. Electric current moving away from the recording electrode cause a negative deflection wave on surface ECG. The first deflection, negative deflection wave on ECG is called Q wave. The second phase of ventricular depolarization is depolarization of the left ventricle and right ventricular free wall. But because the left ventricle is more muscular and create more electrical activity than the right side, so the net electrical current will be towards the left ventricle. And this depolarization vector of the left ventricle is moving towards the recording electrode if we are looking from this side, causing a positive deflection on surface ECG called R wave. Finally, the depolarization wave moves from the apex towards the base of the heart, a little bit away from the recording electrode V6, causing a second negative deflection on the surface ECG after R wave. A negative deflection after R wave is called S wave. So a negative deflection before R wave is called Q, and a negative deflection after R wave is called S wave. So how it looks if we are looking from this side at V1. Again, depolarization of the septum start from the left side towards the right side. So if you are looking from V1, from this area, the depolarization vector of the septum is actually here towards the recording electrode, creating a small positive deflection wave called R wave. Then depolarization of the rest of left ventricle. Here is the vector of depolarization is away from V1 if we are looking from this side, creating a negative deflection wave that come after R wave, which is called S wave. So the QRS complex actually, when we are looking from V1 is different from that recorded from V6 in morphology. V1 look like small r then deep S. In V6 as we just see, it is small q then large r and small s. So here is the ECG paper. It contains 12 lead, 6 recorded from the chest electrode, and this simple part of the lecture, and other 6 limb leads recorded through the 3 limb electrodes. So how these 3 limb electrodes, the right arm, left arm and left foot, give rise to 6 limb leads? This could be explained when we understand Einthoven triangle. So starting with the first 3 set of limb leads, which called augmented unipolar limb lead. Why augmented? Because the electricity recorded at the limbs are of small voltage. So the ECG machine perform augmentation for this electricity. So it is called augmented. Why it is called unipolar? Because it is measures the difference of electricity between this point, right arm or left arm or the foot, and an imaginary point on the machine called the 0 point. 0 point will be explained on the coming slides. So as we discussed before, that the direction of depolarization wave start from right atrium downwards and to the left. So it is away from EVR. So we are expecting that the QRS complex will be negative in EVR because the depolarization wave is going away from EVR. And another picture will be recorded through AVL, and a third one through EVF. So how QRS looks from unipolar limb leads, as we just mentioned, as it is going away from AVR downwards and to the left, so it's expected to be negative in AVR. And as it is going downwards and to the left on the direction of the left foot, so the left foot electrode will record a positive QRS complex, while that of the left arm is midway between both, because also the direction of depolarization wave directed to the left, but it is downward, and it is relatively away from EVL, so it will create a biphasic QRS as seen here. What about the rest of 3 limb bleeds? It is called bipolar limb bleeds, which simply records the difference between these unipolar points. So we have lead 1 that records the difference of electricity between right arm and left arm, and we have lead 2 that records the difference of electricity between left foot and right arm, and we have lead 3 that records the difference of electricity between left arm and left foot. So what is the explanation of this negative charges? As we just explained that the depolarization wave direction is downwards and to the left, so right arm is relatively negative in relation to the left arm, because the direction of current is from right to left, and also it is relatively negative to left foot because the direction of the current is downward. So right arm is negative in relation to left arm and left foot. What about the left arm? The left arm is positive in relation to right arm, but it is negative in relation to left foot, as we just said that the current is directed downward, away from left arm. So left arm is relatively negative to left foot. Left foot is positive relative to both right and left arm, because the direction of current is directed towards EVF. So now we have 3 measured differences between 3 limb electrodes, namely lead 1, lead 2, and lead 3. So how QRS looks from bipolar limb bleed? As we said before, lead 2 and lead 3 is on the same direction of the current downwards, so it will record a positive QRS complex, while similar to AVL, lead 1 is midway between the direction of current, which is towards the left, but the direction of the current is also downwards, away from lead 1, so it will create a biphasic QRS RS like AVL. So where is the 0 point? As we just mentioned, that lead 1 records the difference of electricity between left arm, which is positive, and right arm, which is negative. And lead 2 measures the difference between right arm and left leg. Left leg is positive and right arm is negative. And lead 3 records the difference between left arm negative and left leg positive. So if we sum lead 3 and lead 1, this will give this equation, which is actually lead 2, which is equal left leg minus right arm. Then if we calculate lead 3 sum of lead 1 minus lead 2, this will give the 0 point that we are searching for. So regarding localization using limb bleeds, lead 1 and AVL are looking towards the lateral surface of the heart, while lead 2, AVF, and lead 3 are looking on the inferior wall of the heart. What about the pericardial camera or leads? V1 and V2 is opposite to the septum, V3 and 4 opposite to the anterior wall, V5 and V6 opposite to the lateral wall. To summarize the anatomical group, we have V1 and V2 septal, V3 and V4 anterior, V5, V6 and lead 1 AVL of limb bleeds looking at the lateral surface of the heart. Lead 2, 3 and AVF are looking at the inferior surface of the heart. And so we have explained the 12 lead appear on the ECG, 6 recorded from the 6 chest lead, and 3 unipolar limb bleed, EVR, AVL, AVF, and 3 bipolar limb leads 1, 2 and 3, recording the difference between the unipolar one. When we are commenting on ECG, we are commenting on the duration and voltage of these different waves. So we should know the duration and the calibration of the ECG paper. Each small square here in the ECG paper equal 40 millisecond. How this come? Cause the ECG machine printing on the rate of 25 millimeter per second. So each 5 millimeter equal 200 millisecond, and each 1 millimeter, which is one small square, equal 40 millisecond. So each small square of the ECG paper has a duration of 40 millisecond, and each large square, which contain 5 small square, will be 5 multiplied 40, which is 200 milliseconds. What about the voltage? Each small square equal to 0.1 millivolt. So each 5 small square forming a large square, so each large square equal 0.5 millimeter, and each 2 large square or 10 small square will equal 1 millivolt. The ECG machine print this caliber at the start of each ECG lead. This caliber height is about 2 large small square. This the ECG machine telling us that each 2 large square of the ECG paper equal to 1 millivolt. So the height of the caliber equal 1 millivolt. We have the usual calibration, which just mentioned, which is each 2 large square equal 1 millivolt. But we have the ECG machine have other option if the recorded voltage is huge or large, like a patient with left ventricular hypertrophy. It is automatically change the caliber into what's called half voltage caliber, where each 1 large square equal to 1 millivolt. On the other hand, if we have a very small QRS voltage and we want to magnify it, we perform what is called double voltage, which mean each 1 millivolt will be drawn on 4 large square. So it is important before reading the ECG finding to look at the speed. The usual one is 25 millimeter per second, and the voltage calibration, each 1 millivolt equal to large square, and this is the usual calibration. Moving to the second part of our lecture, which is how to read ECG in systematic approach. Starting with commenting on the rhythm. Normally the rhythm of the heart is originating from the sinoatrial node. That means each B wave of electrical activity is followed by ventricular depolarization or QRS complex, like this ECG. This is called sinus rhythm, and the sinus node fire in a regular way, so we will have a regular rhythm like here, with normal PR intervals that we'll comment on the next slide. In this ECG we have the opposite. We have markedly irregular rhythm of QRS complexes, high variation of the R wave intervals, and we can't appreciate any B wave like this one, just fibrillation wave. So in case of markedly irregular RR interval, absent B wave, and the presence of fibrillation wave like this rhythm is called atrial fibrillation. Second comment will be on the rate, heart rate, with the rule of 300 in regular rhythm patient. That depend on the the fact that each minute contain 300 large square. So the heart rate can be calculated using this equation: 300 divided by the number of large square between each two successive R waves. In this example, we have about 3 large square between this R and this R. So the heart rate will be 300 divided by 3, that equal 100 beat per minute. In case of irregular heart rhythm, we calculated the number of R wave in 6 seconds, which equal to 30 large squares, and then multiply this number by 10. To avoid calculation of 30 large square on the top of each ECG paper, we have this marker. Between each two markers there is 3 seconds or 15 large square. So if we calculated the number of R wave between two interval of these 3 seconds interval, then we will have the number of R wave in 6 seconds. Multiply this number by 10 will give the heart rate. For this is an example. We have 7 QRS complexes between this 6 second interval. So multiplying 7 by 10 will give 70 beat per minute. Third thing is the cardiac axis. Cardiac axis means the direction of the voltage or electrical activity of the heart. How we calculate? As we discussed before, that the direction of this current is downwards and to the left will be on this direction. So the normal axis will be between minus 30 and plus 90. How to comment on cardiac axis? By simple fact that the lead one is at the 0 point or at the x-axis, and the EVF lead is perpendicular to it at 90 degree, creating the y-axis. So by taking the information from only lead 1 and the EVF, we can comment on the direction of electrical activity of the heart. Let's take the different possibilities. If we have the QRS complex mainly positive in lead 1 and EVF, that means the axis will be in this area, which is normal. If we have lead 1 positive but EVF is negative, this means the axis of the heart will be in this area, which mostly be shifted to the left side, causing what is called left axis deviation. If we have EVF positive and lead 1 negative, this will create the axis in this zone, shifted towards the right side, which is called right axis deviation. If both EVF and lead 1 are negative, so the cardiac axis will be in this zone, which is called extreme axis deviation. And here is an example using the rule of thumb. You put your right hand on EVF and left hand on lead 1, and the direction of the looking forward thumb will direct you to the axis of the heart. So if the QRS complex is predominantly positive in EVF and lead 1, so the thumb up in both lead, this is normal axis in this zone. While if the QRS complex is predominantly positive on the right hand only, the thumb is up on the right hand in EVF, so we are in this zone, right axis deviation. If the opposite, which is the left thumb is up and the right one is predominantly negative, so we are directed towards the left hand or left axis deviation. If both thumbs or hands are looking downwards or negative in EVF and lead 1, this will denotes extreme axis deviation axis in this zone. And here is an example. We put the right hand here and the left hand here. The right hand is negative and the left hand is positive, so we have a left axis deviation. Then comment on the ECG voltage. The normal voltage of QRS complex is more than 5 millimeter in limb leads and more than 10 millimeter in precordial leads. Low voltage means that QRS amplitude is less than 5 millimeter in any limb leads. Amplitude means that the whole QRS from the most negative point to the most positive point. The height of the QRS is called amplitude. Amplitude less than 5 denoting low voltage. The cause of low voltage either due to low electricity generation from the heart, like cardiomyopathy or ischemia, or due to impedance between the recording leads and the heart due to effusion, pericardial effusion, pleural effusion, COPD, obesity, etc. Then we comment on the waves or ECG, which is the main core of ECG reading. As we have the B wave of atrial depolarization, the QRS complex of ventricular depolarization, and T wave of ventricular repolarization. So where is the atrial repolarization? The wave of atrial repolarization is hidden within the QRS complex, and it is of low volt, so it is negligible and not seen. Then we have segments. Segments mean isoelectric lines. We have BR segment between the end of P wave and start of QRS complex, and we have ST segment between the end of QRS complex and the beginning of T waves. We comment when we are commenting in waves, we are commenting on the voltage and the duration of each wave. And when we are commenting on segment, we are commenting on deviation of the segment from baseline, either elevation or depression. Finally, we have what is called the interval. Interval means that it contains both wave and segment. So, for example, BR interval equal the B wave duration plus the BR segment, like here. And QT interval from the starting of the Q wave till the end of T wave, which contains a QRS complex, ST segment, and T wave. We are commenting on the time of this interval. Starting with the waves, the B wave, which represent atrial depolarization, both right atrium and left atrium. Depolarization starts at the right atrium, followed by the left atrium, but the time interval between both are very minute, so that when we are recording this electricity from a lead close to the direction of depolarization current, which is lead 2, just parallel to it, it will give a positive deflection wave, which is called B wave. The only lead that record a negative wave is AVR, because the direction is away from AVR. On other leads, it will be positive. In V1, which is on the middle of the chest, it has it is recording the atrial and right atrial and left atrial activity on a biphasic manner, like as we will discuss on the next slide. So we are commenting in the duration of the wave. Normal B wave is less than 3 small squares, and the amplitude of the wave, which is normal, less than 2.5 small square. Prolongation of the duration or increase in the amplitude denoting atrial pathology. The different ECG pattern of atrial enlargement will be explained here. We are commenting mainly in lead 2 because it is the closest lead to the atrial activity. So normally both right atrial activity and left atrial activity are so close and they represent on a single wave on lead 2, which is positive. When we have left atrial enlargement, the left atrium depolarization take more time, so it become more delayed. So we have this pivot B wave and lead to prolonged and notched. This called B mitral, which denotes left atrial enlargement. Called mitral because it is a left atrial enlargement common with mitral valve disease. On the other hand, if we have right atrial enlargement, so the voltage and the duration of the right atrial wave will become predominant and become summated over the left atrial wave, caused a tall big B wave in lead 2. It is called B pulmonale because it is common with chest problem to cause right side heart dilatation. On the other hand, if we are looking on the atrial activity at V1, normally it is biphasic, starting with a positive deflection of right atrial depolarization, followed by a negative deflection of left atrial depolarization, and both are near equal. When we have a predominant negative P wave, this denotes left atrial enlargement. When we have a predominant positive P wave, this denotes right atrial enlargement. So we can diagnose right atrial or left atrial enlargement depending on the B wave morphology, duration and voltage in lead 2 and V1. The next segment will be moving from the B wave to the BR segment and the BR interval, which represent the conduction of a depolarization wave from atria to ventricle through the conduction system of AV node and his Purkinje fiber. So if we have disease in the AV node or his Purkinje fibers, the duration or the time taken by this wave will be prolonged. So what is normal? The normal BR interval is between 120 and 200 milliseconds, which equals 3 to 5 small square. If we have the BR interval, which measured from the start of P wave to the initial part of QRS complex, more than 5 small square or 200 milliseconds, this denote a disease in the conduction system called a first degree heart block. On the other hand, if we have a very short BR interval less than 120 milliseconds or less than 3 small square, this means that the conduction between atria and ventricle bypass the AV node through an extraordinary conduction pathway. This pathway is called accessory pathway, which present in certain disease called Wolff-Parkinson-White syndrome. Then moving to the next station, which is QRS complex, representing ventricular depolarization. We are commenting on the morphology, duration, and voltage of QRS. As we discussed and explained before, that the morphology of QRS is different depending on the camera or the lead recording. When we are looking from V1, it will be small r and deep S. When we are looking to it from V6, it will be a small Q wave followed by R and might be small S wave. So if we have normally also the to reach this morphology from this morphology B1 to B6, we have a progression of R wave increase with time to become a predominant after V3 or V4, which calls the transitional zone. So if we have poor R wave progression, the R wave defined to be less than a small square at V3, this is called poor R wave progression. This might denote anterior wall or septal ischemia. Second abnormal morphology is called Q wave or pathological Q wave. Pathological Q wave is defined by a Q wave more than 1 square in the depth and the duration. It denotes myocardial infarction in this area, because pathological Q is a black hole electrical activity at this wall. So here we have a pathological deep and wide Q wave at V1, V2, V3 that is more than 1 small square in duration and depth. This denotes previous myocardial infarction in the septal and anterior wall in this patient. Then we will comment on the QRS duration. The normal duration of QRS complex is narrow, less than 100 milliseconds or 2.5 small square. So when it's prolonged or take more time for the QRS or depolarization wave, this means that we have a problem in the ventricular conduction system or the His conduction system. The bundle of His is divided into right branch and left branch. Depending on the morphology of the ECG, we can differentiate between a disease in the right bundle or in the left bundle, as we will discuss in the next slide. When we have a disease on the bundle, the electrical impulse have to travel through the myocardium to be conducted to the other part of the heart, supplied by this diseased bundle, which is like moving across the sand. So it take more and more time. So in bundle branch block, we have a QRS complex more than 120 milliseconds or 3 small square, and regarding the morphology, we can differentiate between a disease in the right or the left bundle depending on the morphology. On the disease of left bundle branch, we have white QRS complex plus M-shaped QRS complex in V6, like this one. While if we have disease in the right division or the right bundle, we will have an M-shaped QRS complex in V1. So we can notice also changes on the ST and T wave segment following the QRS complex. Normally, there is a secondary repolarization changes occur on the presence of bundle branch block, which is always on the opposite direction of the QRS complex. For example, if the QRS complex is predominantly positive like V5 and V6 here, the ST segment and T wave will be on the opposite direction, depressed. And if we have predominant negative QRS complex like B1 and B2, the ST and T wave will be in the opposite direction. This point is very important in diagnosis of ischemia in the presence of bundle branch block, as we will discuss on the coming slides. Finally, commenting on QRS voltage, because if we have a patient with left ventricular hypertrophy, the created voltage by this mass of muscle will be of high voltage. The definition of left ventricular hypertrophy from ECG have different criteria. The commonest is Sokolow line criteria, which when we find the sum of deep S wave in V1 plus the R wave in V5 or V6 more than 7 large square or 35 millimeter, this denoting left ventricular hypertrophy. We have also the Cornell criteria, which is the sum of S wave in V3 plus R wave in AVL if exceeding 28 millimeter in men or 20 millimeter in women. This also denote ventricular hypertrophy. Then moving to the repolarization segment, which is the ST and T wave. Repolarization segment is actually very important because following ischemia of the heart, this created changes in the electric channels on the myocytes that lead to changes on the ST segment and T wave. Detection of such changes is very important diagnosis of ischemia in the presence of chest pain presentation. The ST segment, which from the jaw point or the end of QRS complex to the start of T wave, is isoelectric line, which opposite to the plateau segment of action potential wave, as we see here. What is the abnormalities? Deviation, either elevation or depression. So when we define that this segment elevation is significant, Any elevation in any leads apart from V2 or V3 more than 1 millimeter or 1 small square is significant. Regarding V2 and V3, it has a different definition, depend on the age and gender. A male above 40 years require elevation more than 2 small square or 2 millimeter. A patient with age less than 40, male, require 2.5 millimeter. In females, regardless the age, 1.5 millimeter is significant. S-segment elevation denoting an acute occlusion of epicardial coronary artery, and this is one of the most common cardiac emergency. So diagnosis of S-segment elevation is life-saving. The explanation of S-segment elevation on myocardial infarction patient has a very complex theories, but the simplest one is that in transmural myocardial infarction there is a created current of injury related to electrolyte imbalance due to deficiency of ATP. The direction of this current in patient with transmural myocardial infarction is towards the infarcted segment. So it will lead to a positive signal on the recording electrode or elevation like this picture. After we diagnose S-segment elevation, then we have to localize which wall is infarcted. If we have this elevation in 2 or more leads, this signifying that this wall is affected. V1 and V2 for septum, V3, V4 for anterior wall, V5, 6 lead 1 and AVL from limb leads for lateral wall, lead 2, 3 AVF looking for the inferior wall. But we should take in consideration that we have a differential diagnosis other than myocardial infarction for S-segment elevation. The most common is left ventricular hypertrophy, but we will find a voltage criteria of hypertrophy in such patient, and the presentation could be different. We have also syndrome called Brugada syndrome that might cause S-segment elevation, mainly in V1 and V2, which has characteristic shape as seen here, but the presentation will also be different with a syncope or sudden cardiac arrest in young patient. Regarding ST segment depression, more than 0.5 millimeter is significant, and we should know that unlike S-segment elevation, which is localizing, depression is not localizing. So if we have depression in V5 and V6, this doesn't denote lateral ischemia. Denotes ischemia, but we can't localize with depression. What is the explanation of ST segment depression? Usually the ischemia or the incomplete ischemia of the ventricular wall affects the subendocardium because it has more compromised blood supply than the epicardial layer due to the high intracapillary pressure. So when we have a subendocardial ischemia, there is a current of injury directed toward the infarcted area, which will be away from the recording electrode, causing depression. Again, this is a simple explanation. There is a more complex explanation. Finally, how to diagnose myocardial infarction in bundle branch block. As we said before, normally with bundle branch block we have a secondary ST segment and T wave changes that always in the opposite direction of the QRS complex. So if we have changes of the ST or T segment in the same direction of the QRS, mean that the QRS complex is positive and there is ST segment elevation, a concordant elevation more than 1 millimeter in any leads is sufficient for diagnosing myocardial infarction in the presence of left bundle using a criteria called the Scarboza criteria. On the same way, concordant S-segment depression on V1 or 2 or 3 more than 1 millimeter, denoting also ischemia. That means that the QRS complex is predominantly negative and it is followed by a segment depression like here. On the other hand, we just said that the discordance is normal, but if it is exceeding 5 millimeters, this is abnormal also and might denote ischemia. Then coming to the T wave represents ventricular repolarization, and it is normally oriented in the same direction of the preceding QRS complex. The maximum height of T wave is 5 mm in limb lead and 10 mm in precordial leads, and it is slightly asymmetrical. The abnormalities of T wave might be inversion of the T wave. It has a wide differential diagnosis. On top is ischemia, suspected when the T wave inversion is very deep and symmetrical. Might be strain, but we will find the hypertrophy criteria on the ECG. Might be secondary to bundle branch block or electrolyte imbalance like hypokalemia. It's also seen in cases of subarachnoid hemorrhage, but this is actually very deep symmetrical inversion. On the other hand, if we have a very tall big T wave, this is also abnormal. The definition of hyperacute T wave is T wave voltage more than 5 mm in limb lead or 10 mm in precordial leads. Differential diagnosis include very early signs of acute ischemia, hyperkalemia, and hypertrophy. Finally, commenting on the QT interval. QT interval measured from the start of QRS complex till the end of T wave, and include QRS complex, ST segment, and T wave duration. The normal duration is less than 440 milliseconds, and it coincides with this phase of action potential, which is guarded by many electrolyte channel, potassium, calcium. So one of the commonest cause of prolongation of the QT interval is deficiency of such electrolyte, hypokalemia, hypocalcemia, hypomagnesemia. So as we just said, the normal interval is less than 440 milliseconds. Long QT is more than 440 milliseconds, and the risk of prolonged QT is increase the risk of what is called polymorphic ventricular tachycardia or torsade de Bois, a life-threatening arrhythmia, cause the vulnerable period of repolarization phase of the heart is markedly increased in prolonged QT, so that any small electrical activity might initiate a new current or a new electrical activity in this vulnerable period, leading to life-threatening arrhythmia. The QT interval have a more accurate calculation, which is called corrected QT interval from Bassett formula, especially if we have extreme heart rate, very slow heart rate or very rapid heart rate, because the QT interval is also affected by the RR interval. So a very speed heart rate or slow heart rate might affect the interval. To eliminate the effect of heart rate, we calculate the corrected QT interval, which is equal the QT interval divided by square root the RR interval. Other common causes of prolonged QT interval other than electrolyte imbalance include ischemia, include several drugs, antibiotics, antipsychotics, antiemetics, and also ischemia can cause prolonged QT interval. Now moving to the final part of this lecture, which is how to read ECG in a rapid way in the ER. Using this focused approach, we have either a scenario of ischemia or a scenario of arrhythmia. If you have a patient presenting with chest pain, the rapid look will be for the Q wave, ST segment, the T wave, morphology, and then localization of any abnormalities of these waves. On the other hand, if we have a patient presenting with palpitation and we are suspecting arrhythmia, the most important items to check rapidly is the rate, rhythm, the B wave QRS complex relationship, and the QRS duration, as we will explain in the coming slides. Here we have a 46 male patient presenting to emergency with chest pain. So following the rapid ischemia approach, we will check for a Q wave. Then we have here and here and here, and also in V4 a deep and Q wave, which is pathological Q wave, B1, B2, B3 and V4. Rapid look for the S segment. We have ST segment elevation in comparison to the following TB segment, and the elevation is much higher than 1 millimeter. It is about 5 or 4 millimeter, so it is significant S segment elevation. The T wave, we have inverted T wave in the same leads. So the diagnosis here, we have an S segment elevation on the septal and anterior leads, denoting anterior or anteroseptal S segment elevation myocardial infarction. And here is how we localized the site of infarction. V1 and V2 is recording the septum, V3, V4 looking at the anterior wall. So we have anteroseptal STEMI. Now we have a 65 male patient presenting to emergency also with chest pain, again with the rapid protocol, looking for any pathological Q wave. We don't have. Then the ST segment, we have ST segment elevation here in lead 2, lead 3 and ABF, and we have what is called reciprocal depression on the opposite leads, lead 1 and ABL. And regarding the T wave, we have also inverted T wave here and here. So we have inferior lead 2, 3 ABF, ST segment elevation. And as we said, 2 and 3 and ABF are looking at the inferior wall, so this patient have inferior S segment elevation myocardial infarction. Then we have what is called MI equivalent ECG. That means that the patient don't have S segment elevation, but still he has a high probability to have significant myocardial ischemia. We will go through this MI equivalent ECG rapidly, starting with what is called the winter sign. The winter sign denoting acute myocardial infarction or ischemia on the left anterior descending artery territory. The winter sign defined by the breast jaw point or the terminal part of QRS complex is depressed, followed by hyperacute T wave, like this T wave more than 2 large square. The presence of the breast jaw point and hyperacute T wave on the precordial chest lead, denoting proximal left anterior descending artery ischemia, and this mandate a rapid invasive pathway of management, as seen here. The second important equivalent of myocardial infarction ECG called the Wellen syndrome ECG. It denotes significant proximal LAD lesion with spontaneous revascularization. It has two types. Type 1 defined by deep symmetrical T wave inversion in the precordial leads, like this one, and type 2 which entail a biphasic T wave on the precordial leads, like this one. If we see this pattern in a patient presenting with acute chest pain, even if the chest pain resolved, we should underwent invasive approach with urgent coronary angiography for such patient. And finally, when we have a diffuse ST segment depression in different leads with ST segment elevation on AVR, this is the first time to mention AVR, This denotes a marked subendocardial ischemia on a large area of myocardium. This usually seen in a patient with left main artery or multi-vessel disease lesions. So again, this type of ECG with diffuse S-segment depression and S-segment elevation in AVR mandate a rapid invasive pathway of management. The final ECG that might be missed on the emergency, if we have a patient with acute chest pain and the ECG looks like this, we have a tall R wave. As we remember from the morphology of QRS complex in V1 and V2, it has small R wave followed by deep S. Here we have a tall R wave on V2 and also predominantly in V2, followed by deep ST segment depression. This might denote what is called the posterior wall myocardial infarction, because the posterior wall is away from the surface ECG. So myocardial infarction in this wall might cause a mirror image on the anterior chest lead. That means if we record the electrical activity on the posterior wall, this will be the mirror image if we flipped this ECG and looked at these leads. This tall R is actually a deep Q, and this S-segment depression is actually a segment elevation on the mirror on the posterior wall. Isolated posterior myocardial infarction might be seen without inferior segment elevation, commonly seen with inferior elevation, but isolated might also be seen and easily missed. So how to confirm that this ECG pattern is a posterior myocardial infarction? The simple way is to flip the ECG and looking from the back of the paper, we will see that this tall R and S-segment depression is actually a Q wave and S-segment elevation, or perform a direct ECG over the posterior wall of the heart by moving chest electrode V4 and 5 and 6 to this position. We'll call it V7, 8 and 9, with V8 at the tip of scapula, V7 just before it and V9 just after it. If we record the ECG from this zone, we will find this mirror image. So this is an important ECG to be remembered in ER. Finally, a different scenario, we have a 40-year-old female patient presenting with acute shortness of breath 1 week after cesarean section. This scenario is a scenario of pulmonary embolism. So what is the signs of pulmonary embolism that might be striking in the ECG? In pulmonary embolism, there is what is called S1 Q3 T3 sign. That means we have a deep S wave on lead 1, a Q wave and the inverted T in lead 3. This is called S1 Q3 and T3. We might also have sinus tachycardia. The third thing is Q and tall R wave or QR pattern on AVR. This denotes right ventricular strain. And the inverted T in the precordial leads cause V1 and V2 and V3 are recording electricity from the septum and the anterior wall that are partially affected by the right ventricle. So overload over the right ventricle cause T wave inversion on the right precordial leads. All these signs are signs of acute pulmonary embolism, should be taken in consideration. Then we move to the second scenario, which is arrhythmia scenario. Patient presenting with palpitation. How to approach arrhythmia rapidly. Starting with slow heart rate, looking then on the B wave QRS relationship. If we have progressive prolongation of the BR interval followed by a dropped QRS beat, this is called type 2 second degree Mobus type 1 heart block. If we have multiple B waves followed by QRS complex, that means that there is B waves that is not conducted with fixed PR interval. This is called second degree heart block Mobitz type 2. If we have complete loss of the PQRS relationship in a patient with bradycardia, this is called complete EV block or third degree heart block. Then if the heart rate is normal and PQRS complex relationship, we have multiple B followed by QRS, this will denote atrial flutter. If we have absent of atrial activity or absent B wave with irregular relationship, this will be atrial fibrillation. The third possibility is tachycardia. Then we will look into the QRS complex to distinguish between two large differential diagnoses, narrow complex tachycardia and wide complex tachycardia. Starting with narrow complex tachycardia, looking at the rhythm. If the rhythm is regular, then we will look for the third point, which is the PQRS relationship. If we have multiple B wave followed by QRS complex, this will be atrial flutter. Again, if we have QRS followed by B wave or no B wave at all, this will diagnose supraventricular tachycardia or SVT. If we have irregular rhythm, then if there is no atrial activity, this will be atrial fibrillation. If we have multiple B wave followed by QRS complex, this will be atrial flutter with variable atrioventricular nodal block. Regarding wide complex tachycardia, if the rhythm is regular, the two broad differential diagnoses are ventricular tachycardia in 80% of patients, and in 20% of patients this might be supraventricular tachycardia with wide complex due to bundle branch block. If the rhythm is irregular, this also might be atrial fibrillation with Wolff-Parkinson-White syndrome or AF with bundle branch block. So we will move across all these categories right now, starting with this ECG of 33-year-old athlete coming for routine pre-participation ECG assessment. If we look here, we have irregularity in the heart rate, but it is fixed, and we notice that we have what is called group beating, a group of beats followed by a dropped one, a group of beats followed by a dropped one, and the patient is slightly bradycardic. And if we look at the BR interval, starting at this one is normal, this become prolonged, much prolonged, then a dropped B wave. Again, BR interval progressive prolongation followed by dropped B wave, and the QRS complex is narrow. So we have a progressive prolongation of BR interval followed by dropped B wave. This gives the diagnosis of Mobitz type 1 as we see from our algorithm. Second scenario is a 73-year-old lady presenting with syncope. If you look at this ECG, it is bradycardic. We have multiple B wave followed by single QRS complex, multiple B wave QRS complex. That means that this B wave not conducted, then a conducted one, a dropped one, then a conducted one. In a manner of H2 beats, only one is conducted, and the BR interval is fixed. QRS complex is narrow. Back to our algorithm, we have a bradycardic patient, multiple B wave followed by a QRS complex with fixed BR interval. This patient has second degree Mobitz type 2 heart block. Third example, 75-year-old gentleman presenting to emergency with delirium. If you look at this ECG, this patient is bradycardic. We have multiple B waves followed by QRS complex, but if we look at the PQRS complex relationship, it is not fixed, and there is complete dissociation between the atrial activity and the ventricular activity. This B wave is too short to be conducted here, This not followed by QRS complex, this variable PR interval, again variable PR interval, not conducted, conducted with a variable PR interval, not conducted, variable PR interval, B wave on the middle of the T wave, non-conducted, B wave. As it's difficult to create this QRS complex because it's too short PR interval. So we have complete loss of associations or harmony between the atrium or ventricle. So this patient has complete heart block or third degree heart block. There is complete AV dissociation. And when back to our algorithm, a bradycardic patient with loss of BQRS relationship, third degree or complete AV block. The 77-year-old female patient presenting with palpitation, commenting on the rate. The rate is about 70. Let's calculate it. This is a 3-second interval that we explained before. So if we calculated the number of QRS complex in 6-second interval, 1, 2, 3, 4, 5, 6, 7, multiplied by 10, so the heart rate is around 70 in this patient. The rhythm is frankly irregular. The BQRS relationship, actually we don't have a B wave, we just have a fibrillation waves like this one. QRS complex is okay. So we have a normal rate, irregular rhythm with no B wave and narrow QRS. According to the algorithm, we have a patient with atrial fibrillation. Again, 60-year-old female presenting with palpitation, commenting on the rate. Rate is around 70-75. How we calculate it? The number of large square between two RR interval, 1, 2, 3, and 4. 300 over 4 is 75 beat per minute. The rhythm is regular. There is a regular interval between each R and the following R complex. The BQRS relationship, we have multiple saw-shaped B waves followed by single QRS complex. QRS duration is slightly wide. So according to the algorithm, we have a normal rate, regular, with multiple B waves followed by QRS complex that is called atrial flutter. This 20-year-old female patient presented with palpitation. Regarding the rate, the heart rate is very rapid, around 170 or 80 per minute. The rhythm is regular. BQRS, if we look at first time, we don't see any B wave. But if we look carefully at the terminal part of QRS in B1, we will note a small notch that might be a B wave after the QRS complex. The QRS duration is narrow, so we have a narrow complex tachycardia. B wave is not seen or might be seen after the QRS in V1 and regular rhythm. So according to the algorithm, we have a narrow complex regular tachycardia with QRS followed by B wave, or even if we don't see it, no B wave, this will be supraventricular tachycardia. There is multiple types of supraventricular tachycardia, but SVT is okay for provisional diagnosis. We have this 55 male patient, non-ischemic heart disease, presenting with palpitation. So commenting on the rate, this is tachycardia on a rate more than 200, around 150 or 60. The rhythm is regular. The BQRS, actually we can see might be this a B wave coming after the QRS complex. The QRS duration is wide, so we have a wide complex tachycardia. In 80% of cases, wide complex tachycardia is termed ventricular tachycardia, especially in ischemic patients. So according to the algorithm, we have a wide complex regular tachycardia, might be VT in 80% of cases, or the other differential is SVT with bundle branch block. How to differentiate? We have this algorithm called the Brugada algorithm to differentiate between VT versus supraventricular tachycardia and bundle branch block. It depends on certain question. If there is AV dissociation, that means that there is lost relationship between the B wave and QRS complex. If it is lost, that means that the rhythm of the heart is arising from the ventricle, so VT is diagnosed. If not, we move to the next step. If we have initial tall R wave in AVR, this goes with VT. Again, if we don't have, we look at the QRS morphology. If it is looks like a typical bundle branch block, so the probability of bundle branch block is SVT is higher. If it is not look like a bundle branch block that we explained before, so it is most likely VT. Then we have other multiple points, but for the sake of the time and being on the beginning of ECG reading, consider any wide complex tachycardia, especially in old male or ischemic patient, VT until proved otherwise. So we have this 25 male patient presenting to emergency with dizziness. We have a very high rate, almost 280 or 300. The rhythm is irregular. We can see B wave clearly, so we can comment on the BQRS relationship. And the QRS complex is wide. So according to the algorithm, what is the differential diagnosis? We have a wide complex irregular tachycardia that is very fast. Taking in consideration the young age of this patient, atrial fibrillation with pre-excitation or Wolff-Parkinson-White syndrome should be considered first possibility. Other possibilities include atrial fibrillation with bundle branch block. But taking in consideration the very fast rate of this tachycardia, this means that this tachycardia is bypassing the AV node, so it passes through an extranodal tissue. This is accessory pathway commonly seen in WBW patient. And finally, an ECG of a 65-year-old end-stage kidney disease patient who missed his dialysis session and presenting with confusion. We have a very wide complex ECG, barely see any B activity. And what is this? This is called sine wave. This is commonly seen in hyperkalemia. So in this scenario, most of this patient has significant hyperkalemia. Hyperkalemia causes stretching of the ECG. So it causes BR interval prolongation, QRS complex prolongation like this, and might cause T wave hyperacute or peaking of T wave like this patient. So this patient has a life-threatening hyperkalemia and should underwent dialysis after giving membrane stabilizing agents like calcium gluconate. So at the end of this lecture, for more practice, you can visit this useful website. It has a lot of examples of different ECG quizzes and explanation. And finally, thank you.